Dear committee, dear audience, I would like to show you my progress from the last 2 years with my PhD topic about treatment possibilities in oro-maxillo-facial rehabilitation. I'm János König from the Department of Prosthodontics, and my vision is an evidence-based maxillofacial prosthodontics because, believe it or not, this field is heavily influenced by personal preferences and a few opinion leaders. And to achieve this, we have to first, on our part, establish proper scientific output. And here are my few first steps to achieve that. My first project was about surface digitizing or optical scanning in facial prosthetics. And each year, annually and globally, more than 600,000 people develop head and neck cancer, and a small minority of them ends up with a facial defect like this, which is only restorable by prosthetic means, but this prosthetic treatment is inaccessible for many due to the lack of personnel and financial issues. And the only way to acquire a model of this patient's face is to put several layers of impression material on it, which is quite uncomfortable for the patient. But on the other side, digital face scanning can be a viable alternative to digitize the face in a much more quick and comfortable way. But first we have to validate this imaging technology in this specific clinical field by comparing direct clinical measurements taken on the face, and then after digitizing, the same measurements should be done on the virtual models, and by comparing these two sets of measurements, we get the trueness or the deviation from the true values. A null hypothesis was that there should be no difference between scanning technology and scanned facial regions. But what's the clinical significance of this? Is that once we have a skewed or distorted model of the patient's face, then the prosthetic appliance that is fabricated onto this model will be also distorted and skewed, and this can result in gap formation between the silicone and the skin. Now, the threshold of this gap or this inaccuracy is not based on consensus. Some say it's ideal to have 1 or 2 millimeters of accuracy. Some say it's on the sub-millimeter level. We conducted a systematic search in 5 databases, and due to time constraints, I'm only showing you one region, the nasal region, and that's what we have found. This is a mean difference analysis, so what we see that the effect sizes are in millimeters, and what we see is that the overall effects are distributed along the null effect line from -1 or -1 to +1. So that means that there's no systematic skews in the digital representation of the face. However, the precision is on the millimeter level. So the conclusion is that they are quite accurate, but not that repeatable. So it's not in the clinically acceptable range in every region. And we've collected all the difficulties that the articles has mentioned about the clinical usability, and some are more easy to use, some are more complex and more prone to user errors. The implication for practice is that scanning is still preferable over traditional impression because you saw the pictures. And further research should focus on people with facial deficit because this review mostly involved healthy faces. And given that the usability clinically is different, we should also explore the learning curve of scanner usage. As for the strengths, this was the first regional analysis, and since all the included articles use the same methodology, therefore the low heterogeneity we have, and the limitations are that not all regions were involved in the analysis, so the auricular region were omitted since the lack of publications. We submitted this article in the Journal of Prosthodontic Research and was accepted in January. Now, the second project is it revolves around maxillectomy patients and treating them or restoring the function of the maxilla, which can be done surgically and prosthetically, but the choice between these two rehabilitation methods are still controversial, and we aimed to compare these two methods as for the therapeutic effect goes by comparing different quality of life scores, masticatory indices, the speech intelligibility and nasal length, and our null hypothesis was that there should be no difference in the quality of life and in the other outcomes between the interventions. However, our next question, or the other question, was that how do the basic characteristics of the patients influence the effect of the interventions? So, for example, the patient's age, the degree of the maxillary edentullousness, the size of the defects, and if the patient received radiotherapy, and if yes, how much. We conducted the systematic search again in four databases, and at the end we got 14 eligible articles, nine was included in the quantitative synthesis. What we have found is that these are the most common quality of life questionnaires in the literature and in the articles, and we've collected all the domains that was assessed by these questionnaires, and pooled these scores from same domains across or between different questionnaires, and one questionnaire from with different domains. So due to time constraints, I'm only showing you this latter one. And what we can see here is this University of Washington quality of life questionnaire and the mean differences between the baseline and after reconstruction. And what we can see here is these are quality of life scores, which goes from 0 to 100. The 100 means or represents the higher symptomology. And what we have here is the population heterogeneity being quite high, which is due to the baseline differences of the patients, such as the age and so on and so on. And the overall effect is that there's no difference or a slight tendency to favor the surgical reconstruction, and only the activity domain has a significant difference. But given that this is only a point or a score of 2, this is not clinically relevant. The problem was that these baseline differences set the obturator, the prosthetic group, back, because in the one randomized control trial that was involved, the follow-up was sooner, and the most major confounder was that they compared apples to oranges. So a surgical obturator, which is a temporary obturator, to a definitive surgical treatment. So this is was not adequate. And the second clinical questions, due to the lack of the limited amount of articles involved, unfortunately not feasible. So this meta-regression was not conducted, since we should have at least 10 reports included. So the conclusion is that the data suggests no difference between the two choices of intervention, but there's a slight tendency favoring the surgical reconstruction if this is the truth. Unfortunately, due to the limited number of articles and the heterogeneity, this may not represent the truth. The implication for practice is that if these two reconstructional methods have the same effect, then the prosthetic method is much more cost-effective, so this should be the first line of treatment. And of course, we need more trials that are controlled for the major confounding factors. The strength of this review was that this was the first attempt to stratify the population according to the major confounders. The limitations are that, unfortunately, no high-quality studies were conducted in this field, so there's no strong evidence on which intervention to choose. This manuscript was submitted to the Journal of Prosthetic Dentistry and currently under revision. And I would like to thank you for your kind attention with a quote by Mark Twain. The man with a new idea is a crank until this idea succeeds. Thank you very much.
I couldn't see prediction intervals on your forest plots. Why? Your statistician didn't put.
No, there was. So in the final manuscript, the prediction intervals were there. So this was just maybe I have the wrong plots.
And what is the meaning of the prediction interval? Is it useful in every cases?
It shows that if we found another study based on with the same attributes, the value will fall into this prediction interval.
Probably.
Probably.
Okay. And in case if you have 2 or 3 studies, is it meaningful to put prediction interval?
I don't think so, because there's not enough data to extrapolate this prediction interval.
Yeah. Okay. Thanks.
Thank you.
Thank you. For the first review, I think you need to take account in what kind of reconstruction you need to do. Because if we talk about bony reconstruction, it's a hard tissue, so it's not a difference between classic molder and as a scanner. But if, for example, as you mentioned at the beginning, you think that it's necessary to make an epithesis, I think the classic fashion of taking an implant, it's important, because in classic fashion you have a weight. A weight will have also the epithesis, and it is better to make like this than to make with scanner, because scanner will not push the soft tissue. When you make a reconstruction, you want to use the soft tissue, so the precision, of course, it's very important when we talk about this, but we need to take account in other, what do you think?
Yes, this is why we even collected the basic characteristic of both methods to support the claim of this is the digital face scanning is more preferable over the traditional one, because the problem was with our forest plots that the null hypothesis cannot be proven. If the p-value shows us that the null hypothesis cannot be or should be not taken into account, then we know certainly that the error is not by chance, but unfortunately all with this accuracy measurements are, in my opinion, not enough for the clinicians to decide on if they want to replace the traditional facial moulage impressions with a newer technique, and a much more different technique than they are currently using.
And what do you think about accuracy between classic impression, the optical scanner, and if you want to make a comparison to do, for example, an accurate CT scan? We didn't find a huge difference, for example. Do you found something in your analysis?
Unfortunately, we've not included the articles that used CTs for surface representation, but we are currently experimenting with CTs in patients who have soft palatal defects, because the impression taking in that area is even more dangerous than on the face. Mm-hmm. So at least if we get a custom tray to begin with the precisional the functional impression, then it would be a major advancement. Unfortunately, the CTs currently routinely used for the oncological diagnostic purposes are not suitable for accurately segmenting it to a STL file.
For cleft node impression, it's difficult is to remove the rest of the materials from nose, from pharynx. It's a huge problem after this, and the CT scan can be useful. And about the maxillary reconstruction, there is a difference between primary and secondary reconstruction.
Yes. Yes, there is. So there's much more granular than I've presented it, like this. First, we've tried to make a network meta-analysis to compare tooth bone obturators, implant bone obturators, implant bone prosthetics, and so on to each other. But since this area is not that full of with scientific articles, this was not feasible, unfortunately. But the original idea was that we know that it's much more granular than that. So this is why we would like to detect these differences, these small differences, these nuances.
Thank you.
So, as you know, I'm only a dentist. So I know that. So I'm familiar with the intraoral scanners, and I have seen the development of those scanners, and I don't know all the details about the methodology of how to make a 3D model, but I do know, and especially I have seen a decade ago, the intraoral scanners weren't really precise that time. So nowadays it's getting better. I know the model is put together from sections, and that was the problem with that was the reason it wasn't precise. So how about the whole face scanning method? So is it precise nowadays? So how the data, pictures, and fragments are put together?
Well, it depends on the technology. Since if we use a scanner that is capable of providing a detailed surface, then most probably the area of view will be smaller. And on the other hand, then all of these little smaller images should be stitched together, and during the stitching procedure, of course, errors can be produced. Some other scanners are working like a camera, so they just perform one shot from different angles at the same time, and then these 3 or more images will be stitched together. And since the cameras are seeing and viewing the whole face at the same time, this can result in much more accurate dimensions. Unfortunately, the details are then not that great, so there's no good solution for this purpose, I think, currently.
We need further development in the methodology. Okay, thank you.
Thanks.